How's it going, guys? So this is a medium difficulty question for surgery for 2CK. I know this can feel very iffy when you're first studying, but I will keep things real fucking clean and concise without wasting your fucking time, all right? So before we get started, I will be an asshole like I usually am. Tell you to subscribe to my channel, I really appreciate it. Give the video a like, I really appreciate it. And find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's hop into the actual question here. 81-year-old woman, chronic AFib, severe abdo pain for the past 2 hours. Physical exam shows mild abdo tenderness. You need to know as a baseline standard pass level diagnosis, this is acute mesenteric ischemia. Now I said this is a medium difficulty question because we obviously expand upon things, but you need to know that if you have a left atrial mural thrombus in the setting of AFib, that can launch off to the brain, cause a stroke or TIA, go to the eye. Acute retinal artery occlusion can cause acute mesenteric ischemia if it goes to the SMA or IMA, as we have here, or it can even go to the femoral popliteal vessels, cause acute limb ischemia. Patients classically and colloquially get pain out of proportion to the physical exam. So this patient has severe abdo pain, holy shit, but the physical exam, nothing outrageous. Bowel sounds are absent. This is a non-specific finding that can cause a lot of fucking confusion on USMLE. It does not necessarily mean that we have complete obstruction. It can also be seen in the setting of stress, sympathetic activation, okay? So as we have here, clearly, fecal occult blood is positive. This is also a non-specific finding that caused confusion. We, of course, have to consider differentials such as diverticular bleed, colorectal cancer, angiodysplasia, IBD, etc., pancreatitis, I've seen it. But these two findings, bowel sounds and fecal occult blood, nothing to get pulled into. Leukocytes elevated. We obviously want a normal range 4 to 11. This is 25. We obviously want to consider things like infection, sepsis, but we can also get elevated leukes in the setting of stress, as we have here, sympathetic activation. Arterial blood gas. Now look, I know some of you are going to feel a bit weak on your acid base. This is why we do step 1 before step 2. It's somewhat implied that we know this stuff already. Now we've clearly got a low pH, normal range 7.35 to 4.5. CO2 should be 33 to 44. So we have CO2 at the lower end of normal. CO2 is acidic, we're blowing it off. So therefore, the only way it's possible to have a low pH in the setting of a low CO2 is if we have a metabolic acidosis and low bicarb, which is due to lactic acidosis in this case. If we have decreased oxygen delivery to tissues, we're going to have increased anaerobic respiration and lactic acid production. Very fucking high yield for USMLE, especially for shock. Okay, I mean hypovolemic, cardiogenic, septic, I've seen it all. Okay, lactic acidosis, very important, but that explains our low pH here. Ischemia. Abdominal X-ray shows a non-specific gas pattern. We do abdo X-ray, AXR, when we're looking for gas, okay? You might do it for volvulus, see a coffee bean appearance in an elderly patient. You might do it for toxic megacolon, okay? Shown in large cecum. They say 12 centimeter cecum. I've seen that finding on questions. And also chest and abdominal x-rays, the combo I've seen for when you're looking for viscous rupture, air under the diaphragm, if you have a duodenal perforation, okay? Very fucking high yield. So they probably did it here because the bowel sounds are absent. So we just have to at least cover our bases, rule out a physical obstruction. Let me just hop through the answer choices. Colonoscopy, wrong fucking answer. I mean, look, obviously a myriad of things we could do colonoscopy for. We want to diagnose cancer. We want to do diagnose IBD. Okay, so colonoscopy has its utility, but in the setting of acute mesenteric ischemia, it's not what we do. CT scan of the abdomen, wrong fucking answer. Now look, this is high yield for how we diagnose diverticulitis. You need to know that you don't do colonoscopy in acute diverticulitis because you could cause perforation. Same thing for toxic megacolon. You do not do colonoscopy. When the diverticulitis heals, when the patient convalesces, weeks to months later, you schedule follow-up, do a colonoscopy to rule out colon cancer as an etiology for the diverticulitis. Choice C, exploratory coleotomy is our correct answer. Now look, every fucking student says, what the fuck, when they see coleotomy. This is a vocabulary exercise. This isn't because I'm trying to be entertaining here. This is literally what shows up in the 2CK NBME forms, okay? Coleotomy just means laparotomy. If you Google it, you'd be like, what the fuck? Like coleotomy, same thing as laparotomy? Never heard of that. I know, it's weird, okay? It's like this shows up on the 2CK NBME subject-specific forms, the clinical mastery series forms. You're going to do a laparotomy if a patient is unstable, has low blood pressure, or if a patient has acute mesenteric ischemia. It's what they want. You're not going to do laparoscopy in these patients. Laparoscopy, more conservative if the patient has normal blood pressure, or if they just have something like an appendectomy that needs performed and the patient doesn't have low blood pressure. Cholecystectomy that needs to be performed if the patient doesn't have low blood pressure. But in the setting of SMA or IMA occlusion in mesenteric ischemia, we are going to have to remove necrotic bowel. Okay, and that's why a laparotomy slash ciliotomy, holy shit, is what we do. Now, some students will say, but I don't get it. I thought like giving IV saline is like a very typical answer in USMLE. It is. And you might say, well, wouldn't we at least give this patient saline first? We would, but we definitely wouldn't observe. Okay, we definitely are going to intervene with a ciliotomy. You need to know ringer lactate is the same thing for all intents and purposes on USMLE as just 0.9% normal saline. I believe ringer lactate might have a little bit of potassium in there, maybe some phosphate. But as I said, for USMLE, ringer lactate and 0.9% sodium chloride, just same thing for normal saline, all right? Paracentesis, wrong answer, but very important vocabulary word for 2CK. This is just aspirating fluid from the peritoneal cavity. This is what's done for SBP, spontaneous bacterial peritonitis. Do not confuse this with pericardiocentesis, okay? A lot of students do that. SBP, obviously, it's a lengthy discussion in of itself. I've made other questions on it. But if a patient has diffuse abdo pain, high temperature, has cirrhosis, hemochromatosis, Hep B, Hep C, alcoholism, has nephrotic syndrome, or is undergoing peritoneal dialysis, we could do a paracentesis where we look for greater than 250 white cells per high-powered field. We do a gram stain of the fluid. We give ceftriaxone. So look, as I said, I'm not going to make this a 49-minute clip where we talk about every little fucking detail, but that's your concise clip here. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.